I'm so honored to meet up everyone again at the ICC webinar. My name is Pear. Today I will be the co-moderator with Dr. Junia Tu and Dr. P.Y. Cho. And we have a distinguished attendee from Thailand, Dr. Katun Buddhathida Wangsrimongkol, to give us the lecture tonight. And we also have 3 panelists to join our discussions. The first panelist, Professor Ellen Cole. She is the professor at Departments of Craniofacial Orthodontics and the directors of the Craniofacial Research Center, Chang Memorial Hospital, Taiwan, and she's the chairs of the APOC-TAO 2024, which we're gonna have the meeting this year in December. And the second panelist, Professor Nadeep Busi, a General Secretary at Cambodia Associations of Orthodontists and a lecturer at University Pusi Satra Phnom Penh, Cambodia, and a fellow of World Federations of Orthodontists, or WFO, which is a very well-known organization among international orthodontists. And the third panelist, Professor Janet Pendant, the former president of Associations of Philippines Orthodontics in 2021 to 2022, and a fellows of WFO as well, and a craniofacial orthodontist at Nordorf Craniofacial Foundation in the Philippines. And I would like to introduce our speaker to everyone. Dr. Katun, or Dr. Buddhathida Wangsrimongkol, also known as Dr. Katun, received her dental degree first class honor from Chulalongkorn University, Thailand. After 2 years as the general dentist at Konkan University, she flew to the US to pursue orthodontic residency training. And she received her orthodontic specialty training and a Doctor's of Medical Science degree in oral biology from Harvard School of Dental Medicine in 2018. And following years, Dr. Katun completed her craniofacial and special care orthodontist fellowship training at the Universities of Michigan School of Dentistry, where she worked with the craniofacial team at CS Moth Children's Hospital. Her journey did not stop there. The year after, she completed her craniofacial orthodontic research fellowship training at the Weiss Departments of Plastic Surgery and NYU London Health. And Dr. Katun returned to Thailand at the end of 2020. Since then, she had completed a full-time orthodontic faculty at Konkan University, Thailand. And she worked as a part-time as the orthodontist at her parents' multidisciplinary practice. Her research heavily involved in the innovation in cape care, and she is currently holding the U.S. patent pending device and the 3 patents pending in Thailand. And her research interests rise in the cape care and palate and other craniofacial anomalies, as well as digital technology for patient care. And now it's time for Dr. Katun presentations on the topics of digital Naso-Alveolar molding. And welcome, Dr. Katun.
Hi, thank you so much for the introduction. Can you hear my slides well? Can you see my slides well?
Yes, yes.
Okay,
yes. Yeah, very clear.
Let me pull up the presentation mode. Okay, thank you again for the introduction, and thank you ICC for having me today. So the topic will be the digital naso-alveolar molding. I have no conflict of interest to declare. So to revisit again, my name is Buddhathida. It comes from Buddha and daughter. So it's mean the daughter of Buddha is actually scary to see and pronounce is actually very easy to pronounce. You can call me Cartoon, that's my nickname. I completed my dental degree from Chulalongkorn University, Thailand, before I completed my orthodontic training and Doctor of Medical Science in Oral Biology at Harvard School of Dental Medicine. I completed my craniofacial and special care orthodontics at University of Michigan, where I met amazing people and enriched my training. To further my education, I went to New York City to do a craniofacial orthodontic research fellow for another year before I returned back to Thailand. And I'm currently a full-time faculty at Konkan University. My experience is pretty unique. I experienced not one, not even two, not three, but actually 4 cleft teams. And I'm excited to share my experience with you guys today. So Khon Kaen is in the northeast of Thailand. We're known for our rich and beautiful culture. And we're also known for dinosaur fossils and beautiful Mother Nature. We're famous in our amazingly delicious Isan food. And I'd like you all to try them all one day. In today's presentation, I will revisit the history of pre-surgical infant orthopedics, the progression of appliance design and treatment techniques, before progressing to how digital technology fit in the whole picture. I will also highlight what we are currently doing at KKU and what I think the future has in store for us. So pre-surgical infant orthopedics is the orthodontic technique that used to mold the alveolar and sometimes nasal tissues of the infant with cleft lip and palate. It is to restore the ala base and maintaining skeletal and soft tissue harmony, all to facilitate the primary lip repair surgery and to reduce the post-surgical complications. It is the umbrella term for all these appliances listed in the slide. PSIO started with extraoral compliance, oral appliances like bondages to exert forces on the projected premaxilla, and not until the 50s when the intraoral device and model setup was introduced. This was the modern concept of PSIO. In the years to follow, many appliances were invented, including passive plate and latham appliance. But all of these techniques help reduce the severity of cleft size, but not the nose part. Here comes a paradigm shift of PSIO. It started when Matsuo first described a neonatal ear molding that taking advantage of estrogen surge in the fetal blood right after birth. This abundance of estrogen level results in relaxed ear cartilage that is easily to mold. And of course, this applies to the nasal cartilage as well. So after reading this article, Dr. Barry Grayson of New York University started incorporating nasal molding in his PSIO care by adding the nasal stent into his molding plate. This paper was published 9 years after Matsuo first described the cartilage molding. We reported a great result in infants with bilateral cleft lip and palate. In this paper, he highlighted the repositioning of alveolar segments and premaxilla, also the lateral nasal cartilage molding, as well as the columella and prolabium elongation. He coins the term Naso-Alveolar molding, or NAM, and that's marked the paradigm shift of PSIO care. So over the years, NAM has been revised and improved, but even the original design or the new design, they all have the 3 major components. The nasal stent, which is the nose molding part, the molding plate to mold the alveolar segments, and the retention button. That's to keep the NAM plate in the baby's mouth. And another important part in the NAM is the lip taping and the retention tapes to hold the NAM plate in place and to exert some forces on the segments. This was the original Grayson NAM at NYU Langone Health. I was excited to see it in real life, and I'd like to share that with you today. To revisit the concept of alveolar molding and biomechanics of NAM, I'd like to first kind of categorize the PSIO in what today's world. So the lip adhesion is nothing, we're not going to talk about it today. The PSIO consisted of the intraoral appliances and extraoral appliances. And you can categorize further by the removability of it or the type of force that you use. I'm going to go focus today on the passive and active appliance. During my training in Michigan, I was lucky enough to visit NYU and train with Dr. Grayson for only 2 days for the concept of naso-alveolar molding, and I will revisit the technique with you today. So before we understand the nasal molding, the alveolar molding as well, here are the anatomy of the baby, the greater segment, the lesser segment, the nasal septum, the nostril of non-cleft side and the cleft side, and the columella. During first appointment, you want to deliver after taking impression, the first week later, you deliver the passive plate. And in order for you to understand better in terms of AP relationship of the plate relative to the baby's face and mouth, the top gray line is the front part and the bottom gray line is the back throat of the baby. 1 week later, after you see the baby, you start selective grinding of the plate by removing the hard acrylic inside the plate, adding some hard acrylic and also adding permasoft on the inside of the plate, and then cut away the back of the plate. After applying some forces, the plate will be pushed back towards the throat of the baby, and it will bring the greater segment towards a lesser segment. You continue to do that weekly visit, adding acrylic, permasoft, exert some force. And that's when we have the alveolar cleft molding. And the initial goal for Grayson NAM is to get cleft gap to 0 to 1 millimeter for a GPP procedure. So that's what I learned from Dr. Grayson when he was teaching the course. But when I learned what I see in the clinic, when I walked around at NYU, it's a little bit different. So this is sort of like a modification of the Grayson NAM, which is the differential force application method. What we do, what they do over there is at the second visit, when you deliver the passive plate for the baby to kind of get used to, you start removing the hard acrylic inside on the lesser segment, adding more acrylic to the plate for the thickness, and cut away the hard acrylic at the end of the plate, but more on the lesser segment. After applying the force, you do instruct the parents to pull towards the cleft side more than the non-cleft side, and that's render the rotation of the greater segment towards the lesser segment. You do that every week to keep molding and eventually allow growth and the molding force to do its job. That should be the result after the NAM technique. So what are else out there? The passive plate is another way that you can do alveolar molding. The way that passive plate works is that you grind away the inside of the plate and you add more acrylic at the outside. You let the nature do its work and allows the baby's growth to happen. So what else affect alveolar molding techniques? The philosophy of the team, the resources that you have, your training experience, your team in general, and if your surgeon like to do GPP or not, and also the nasal molding method. So I like to touch base on the concept of nasal molding just a little bit. For the nasal molding to be work effectively, the force need to exert in the middle of the nose because that's where the lateral nasal cartilage is. You don't want to mold the lateral part of the nose. So in this picture, you see that the nasal stent is located towards the medial part of the nose than the lateral. If you look into literature enough, you'll see that original Grayson technique recommended start nasal molding when the cleft gap is less than 5 millimeter. So let's see if you start molding when the cleft gap is more than 5 millimeter. What happened is the greater segment continue to mold and it will mold towards a lesser segment. And your nasal stent will start to go lateral, and that's when you start to have meganostril. So that's why the nasal molding part is actually the hardest part in the NAM therapy. So what are the other options that you have? Dynaclef is one of the options, the forehead type appliance that you can apply force, the upward but backward direction for the nose. Other group have done the prefabricated softer material for the nostril. My great friend, Martha Mejia, has her own appliance called the in-plane device, and it uses in different sizes. The appliance called the rhinoplastic appliance system. But great mind think alike. During my training at NYU, around COVID time actually, I get I had the privilege to help design the nostril molding device that has a lip pressure component. This device is still patent pending, and it is a grandfather version of the Plana appliance that is recently published this year. So let's talk about conventional NAM. Conventional NAM started with impression taking, and it can be the PVS impression and the upside down baby version, but you need an oxygen tank to be a support system for you, a backup system, so to speak. What we do at Kangan University, we use alternate impression, and this video is a 6 times speed. We have a double layer sandwich technique that sandwich the gauze in the middle. We have the parent holding the baby. The operator in this video is actually our resident, and we have the nurse practitioner and the assistant to help during impression. So it's a big fun party when we have to take any impression on the baby. Next is the model pour up. And after model pour up, then you have to fabricate NAM plate using salt and pepper technique. And it's very time consuming. Eventually you add the nasal stent after multiple clinical visits. When the baby's ready for nasal molding, then you start to do that. So with conventional NAM, there's always airway risk from impression taking. It requires specific laboratory work, and it requires significant chair time. Sometimes it takes 1 to 2 hours for plate adjustment and nasal stent activation. It requires highly experienced clinicians, and it requires frequent appointments, which is weekly appointments. So let's talk about the digital disruption in PSIO. Over the past 13 years, there are so many publications regarding digital NAM. I had the privilege when I was at NYU to expose to some of these digital technology, get to design some plates and play around with 3D printing. With the digital NAM workflow, you started with the model scanning or the intraoral scanning, depends on the resources that you have. And then you can perform treatment simulation to the program of your liking. And then you can perform the virtual appliance design and the serial models or plates fabrication. I categorize digital NAM into 2 techniques, the serial model techniques and the serial plates technique. For the serial model techniques, you print the model and you fabricate the NAM plate with conventional acrylic plate or the thermoform aligners. The serial plate technique, you can direct print the aligners or the plates by yourself. For the nasal molding component, you can do the conventional stainless steel wire or the extraoral molding device or the direct printed nasal molding device. With the serial model techniques, again, you started with impression material, impression taking. So you have to scan the model into the computer. If you direct scan, then you can load the STL file into the program of your liking. You then perform the master model segmentation and treatment simulation to your philosophy. You can 3D print out the models, like I mentioned earlier. If you didn't blocked out in the program, you have to pan blocked out like you can see in this slide. If you can block out the model in the program as well. Then you can perform the manual plate fabrication and thermoform aligners in some technique. For the nasal stent, you can add it manually, or you can use the extraoral for the extraoral activation. For the serial plate techniques, again, similarly with the impression or scanning. Next, you do the model segmentation and treatment simulation in the program. On the left side is the passive plate technique, and on the right side, or the yellow models, is the active technique. Then you design the virtual plates in the program before you 3D printed the plates. It will come out as serial plates that continuously changes the alveolar segments. Some other systems, they are actually very creative, and they make like a click-in system where you can kind of screw the nasal stent part into the plate. Some you just have to add manually, and again, you can use a forehead type of nasal molding. So in conclusion, the digital NAM workflow comprises of two techniques, the model techniques, the serial models techniques, and the serial plates technique. Again, you start with the intraoral impression or scanning, you perform the treatment simulation, and you can fabricate your appliance with the conventional way of salt and pepper or thermoform aligners, or the direct print of the serial plates to your liking, and the nasal activation. So do digital NAMs work as well as the conventional one? This paper is actually recently published this year, March of 2024. It's a systematic review and meta-analysis. It included 9 studies in the paper, and the conclusion was that digital NAM is actually effectively reduces severity of cleft alveolus and the nasal outcome measure as much as the conventional one in the unilateral cleft lip and palate, and also in the bilateral cleft lip and palate. They also mentioned that for the digital technique, it requires fewer patient visit and reduced chair side time to prepare when compared to the unconventional NAM. So the digital NAM reduced risk of airway obstruction related to impression taking, no doubt. It required less lab work, although it required more digital setup. It reduced clinical chair time, and it required less clinical skill when you don't have to adjust your appliance chair side, trust me. It also reduced the number of appointments. You can reduce the appointment to bi-weekly or even monthly appointment if you have the serial plates, and you can give the patient a couple of plates at the same time. What about the other side of the coin? The CAD software, the computer aided design software, can be expensive. You still require a lot of plates. What if the mother's missing some plates, right? And it's still limited to 1 to 2 millimeter of movement per plate. It requires weekly change, weekly adaptation of the baby, and it still requires manual addition of the nasal stents and sometimes the forehead type nasal stent. It's not bad, it's an option. I had a privilege to present my work at the Dentsply Sirona World in Las Vegas last year, and to be part of the great minds in digital cleft team. We had our 5 seconds of fame on the stage with Smile Train, and I'd like to thank Smile Train for having me and for giving us this opportunity. Now we talk about the techniques around the world. What do we have in Thailand? Khon Kaen University Orthodontic Department is part of the dental school in the purple, and the blue is the medical school. The division of orthodontic is right next to the cleft center, Tawanchai Cleft Center. We have the open floor plan in the clinic. We have 2 classes of residents for a 3-year training. Some of the year we have 4 to 8 residents, and we have full-time faculty. There are only 3 of us who supervise NAM cases. We have 7 clinic sessions that work 9 to 12 and 1 to 4, and lectures from 8 to 9 a.m. We occasionally have special lectures, invited speakers that came to our department, but residents still have NAM duty. Not a lot of orthodontic residency training will have this exposure. The practice that we have is what we call KKU NAM. It's an acrylic plate with active screw, and we have a forehead type nasal molding device. Residents have to make NAM plates by themselves, and there are a lot of surprises. If you'd like to learn more about KKU NAM, you're welcome to look into this paper. So again, our residents have to see babies in the clinic by themselves. This is one of the residents who's scanning the intraoral of the baby, and we have the extraoral camera, the stereophotogrammetry in the clinic as well. Because of the busy schedule of the residents, that's why we started to bring digital technology into our program. So KKU IDNAM is the individualized digital naso-alveolar molding. We started this technique since 2021, all to overcome the limitation of an academic setting, to provide smoother service for the patients and for research opportunities, and to improve the cleft team workflow overall. We're the first center in Thailand to utilize digital technology in NAM therapy. It is a full digital workflow complete of data gathering, treatment planning, appliance design, and fabrication. IDNAM is an active plate. It utilizes the Grayson force, a differential force application technique. It is direct 3D printed. The plate design is very similar to passive plate, but has some predetermined selective grinding areas. It consisted of two plates. The first plate is the molding plate without naso stent, and the second plate consisted of molding plate and naso stent. Our nasal activation protocol is separate. We use a nasal silicone cap or nasal silicone molding extension with 1.5 millimeter per activation for this. So the biomechanics of IDNAM, basically when you deliver the first plate, this plate is already have the predetermined selective grinding area. You utilizes the selective the differential force application to exert the force on the greater segment and rotate the plate. The plate stays in the baby's mouth with the retention tapes, and you cannot exert too much force, otherwise the baby will cry or the plate will come out. You actually need to apply gentle force, but you can have the parents increase the force every so often. Once the cleft gap is around 5 millimeters, when we printed our second plate with nasal stent in place, we continue the molding, and we achieve the result when we reach 3 to 4 millimeter of cleft gap. That's a plate 1, and that's a plate 2. So the IDNAM workflow, again, include data acquisition, virtual planning, and 3D printing. For data acquisition, these are all the intraoral scanners, not that we have, but all that I tried. So the ones that we have in our program is the 3-shape Trios 4 and 5, and the Dexis IS 3800W. We find that these guys work really well for newborns. This is a video of me scanning the baby. We started with a lesser segment. Sometimes you can start with a greater segment. You cross the midline, you go to the tuberosity area, and then you try to capture the vestibular area, and then you come around to the front again. It usually takes around less than 2 minutes to capture everything. When you compare the Dexis and the Trios 4 wand tip, you can see that Dexis has actually 2 sizes, the normal size and the smaller size, and they work really well. The next video will show the Dexis scan in the middle. So this is a 4x speed video, but I was able to capture the baby's alveolar in only 2 minutes. So usually the baby would lie and have facing me or the operators. The parents are stabilizing the head of the baby, and that's when we got our intraoral scanning. You can actually scan. You can actually scan with the nasolabial part, so you can get all-in-one scan. Now the virtual planning, we use Blender software. We import the file of the nasolabial and the intraoral file, and then we perform the model segmentation. We modify the model, and then we design plate, and we add the retention button and naso stent as needed. This is how it looks like with the overlaying the IDNAM plate 2 and the scan of the baby. What we use for printing, we use Form 3 to print the dental LT clear resin. It's a class 2A long-term biocompatible resin. It's ideal for long-term orthodontic appliances in the mouth. And this is how the plate 1 and plate 2 looks like. This is our nasal silicone molding extension, and we have 3 sizes available right now. So resident just add this silicone to our second plate before deliver to the baby. So with KKU IDNAM, we use the freely available CAD software, but to be able to do all that I showed you earlier, we need to spend around $300 on the dental module add-ons. We only have 2 plates instead of 0 plates. There was no limit per movement per plate, and there were no weekly change. The nasal stent is incorporated digitally. And we use nasal silicone cap for activation. So to revisit the protocol, when we see the baby at initial appointment, we take initial records, we apply lip taping as needed. 1 week after, we deliver the NAM plate 1, and we follow the babies on a bi-weekly basis. Usually around 1 month or 1 month and a half, we were able to get the cleft gap to around less than 5 millimeter, or sometimes we look at the labial frenum. If it's at the mid-sagittal plane, then we start scanning for the second plate. So this protocol also mirrors what KKU NAM already had. That enable us to do more analysis further. And the scanning around 1 or 1.5 months actually goes along with this paper. They talked about a study in healthy newborns. They found that between newborn to 5 months, the baby maxilla actually grow in the longitudinal and transverse direction for 4 millimeter and vertical growth at a tuberal level for 2 millimeter. And that is 1.2 millimeter per month in the first 3 months in longitudinal plane. And for the transverse growth, it has the greatest rate in the first month. So after we took immediate records, the week after we delivered the IDNAM plate 2 with the nasal stent, we activated it on the bi-weekly basis with the nasal silicone molding, and we take pre-surgical records again when we reach rule of 10 or cleft gap is around 3 to 4 millimeters. And you can appreciate here that we were able to approximate greater and lesser segment pretty nicely. For post-surgical records, we deliver nasal creator device is also another innovation at our department. It was adopted by the National Health Security Office, and you can find it on the QR code here. I have no conflict of interest. It's only $20 per piece, so it will be useful for your patients for sure. So why don't we need to mold the alveolar segment to 0 millimeter? Our group show that cleft gap is actually significantly reduced after the rib repair surgery. So if your surgeon, your team don't perform GPP, you don't really need to get the gap to 0 to 1 millimeter. Sometimes it's more burden on the patients and the family than, to get that 2 millimeter. These are the PettyPen related to our device. And if you'd like to learn more about our IDNAM, we actually just published an article, a case report in JCS earlier this year. I have a privilege to take my residents to Milan to present and meet great minds in cleft orthodontic world. Our residents get to present their work, and these are some of the results in the IDNAM project. We also had an oral presentation showing 12 first cases of the IDNAM technique. And I can show you the preliminary result here. We were able to decrease the anterior arch width and intercanine width for the alveolar segment and increase posterior arch width and arch length of the greater and lesser segment. For the nose outcome measures, we saw increase in nose projection, nostril height, and on the cleft side, the columella length, and the nasal base columella angle. And these are some of the cases. I'm happy to share that you'll be able to read this in full text in a couple of months, since the paper was just accepted for publication at JCS. And you can see the date there just a couple of weeks ago. We also have the downloadable supplemental materials that highlighting some of the more daunting steps in designing the plate. So what are the other side of the coin? Blender is a software. It's not an easy software. It's also time consuming when it comes to digital planning. So here I present you some other options. If you have access to Ortho Analyzer, it's one of your options. Another group in Basel, I have their resources list on the right-hand side. They show how to use an Autodesk Mesh Mixer program, which is a free software to design a passive plate if you're using a passive plate technique. This is another program, the Titan Dental Design. It's an orthodontic treatment program for aligners, but I apply in this scenario for the zero plate technique. And you can see from the video here. So I have a summary for you here. In terms of software cost, Titan, Mesh Mixer, and Blender are free software. You have to pay for Ortho Analyzer. And I think they have changed their name to Ortho Studio or something. In terms of extension, you don't really need it for Titan Mesh Mixer, but you need extensions for Blender. You also don't need it for Ortho Analyzer. If you want to export the STL file that you make, you have to pay it for Titan, but you don't have to pay for the rest. But Titan is actually very easy to use because it's a clear aligner program for orthodontists. You're used to the program already, and so it's not a big learning curve. Mesh Mixer and Ortho Analyzer is not so hard to learn, but Blender, it's so complicated to learn. If you're using the serial movement techniques, Titan is really good for your technique. Blender and Ortho Analyzer are really good as well. For Mesh Mixer, it's probably better for the passive plate. In terms of versatility, you can't really do much with Titan. You can only make the serial movement and then export the STL file, but you really can't do in terms of adding other components like retention buttons or a nasal stent. You can do that in Mesh Mixer and Ortho Analyzer, but for Blender, it's very easy to do. What else? So the accuracy of nasal stent placement is actually quite hard because you're dealing with the soft tissue and the moving parts. So this is why we have the updated protocol in 2024. That's when we start using our digital nasal stents, which is another innovation at our department. We use DNS at first appointment, so we can start molding the nose right away. We don't have to wait until the gap is 5 millimeters. And that's when you can scan for the second plate and you can have the better approximation of the nasal stent. This is how we do it now. So we started with lip taping and the DNS before we progress with first plate and DNS. And then we transition to the second plate and finally the nasal creator device after surgery. So the question is, do we still need IDNAM plate 2? Let this video show you. So if you look carefully, these two babies, when they're feeding, you get the exertion of force more than the static of DNS. So if you can do it, if you can make the NAM plate with nasal stent, that's great. But if you can't, it's not the end of the world. So what else? What about the effects on alveolar ridges? To understand more of what our IDNAM affect the baby's alveolus, one of my residents performed this study, and hopefully we can publish the result sometime soon. We compare the result from IDNAM and KKUNAM. He presented his results in Milan earlier this year, and our initial results show that both techniques, the digital and conventional, show equally effective results in nasal and alveolar molding. So what does the future hold? I think this is the era of AI and deep learning. And the team in Basel already achieved it. They published a paper in 2023 for the automated and data-driven plate fabrication using Blender software by marking some of the landmarks to auto-generate the plate. This is for the passive plates. We're actually doing the same thing with the collaboration with the Faculty of Engineering, where we're trying to find the best way to bridge both greater and lesser segment and to create active plates for the baby and ultimately for the passive plate as well. If you like to learn more and start digital with your team, here are some of the resources that I have for you. Catherine Preston, my great friend, has a platform called Bite Size Dental Education, and they have the digital NAM topics by Dr. Bose, who is also my other great friend for you here. You can also look up the FDI website, and the Cleft Orthodontic Digitization Task Force put together all these amazing material that will be so useful for you. And if you'd like to learn more, the textbook from Dr. Chetier and Dr. Gibson is a great resources for you. My take-home messages today: there is no incorrect techniques or philosophies in NAM therapy. You have to embrace the digital technology. It is here to stay. Choose what is best in the context of your team and your patients. You don't really need expensive tapes or devices to achieve good results as long as you understand the biology and biomechanics. Be your patient's advocate. Read a lot, review literatures, ask if you have questions. Make great friends, great connections, learn from them. This community can only be enriched when we are here to give. And I'd like to end this presentation with my favorite quote: a creative man is motivated by the desire to achieve, not by the desire to beat others. I'd like to thank my team to make my journey, the education journey, the training journey, the Chang Memorial Hospital for the warm welcome. And I'd like to thank my KKU family and my private practice family, and also my parents for their unwavering support. Thank you so much. And my contact information are below, so you're welcome to ask any questions if you have. Thank you so much.
Thank you so much, Dr. Cartoon, on this very in-depth presentation on NAM treatment. And at this time, I'd like to invite our panelists for some panel discussion. So first, I'd like to invite Dr. Ellen Ko. Dr. Ko.
Thank you, Dr. Cartoon, for your wonderful presentation. And it is really a really nice work to do such a very delicate NAM. And we, in our craniofacial setting, we haven't get into the digital NAM. We use one play from first appointment to the end. And when we do the alveolar molding, we just taping, so we don't know where we are moving the greater segment more or lesser segment more, usually greater segment more. But for this kind of active play, it can be really accurate titrate what you are going to plan. So I want to ask you that you have mentioned that for this technique of digital plate for 1 millimeter activation, I saw that some center they use more than three active plate, and some use just three, like China, and you have modified into two. And what's the difference? Yeah.
So I think the difference is if you have a slight activation, you still have the material between the greater and the lesser segment. For me, it's like a combination of passive plate, but we still apply some forces to it. So we did the modification at the end of the plate to allow some rotation to happen. So for us, it eliminate the the gauging, the doping of how much growth will occur, how much rotation can happen. We allow pretty much the force that maintain the plate in place and how the babies can tolerate to really allows more more rotation of the greater segment. Does it give different results? I don't have that. I don't have that answer, and I'd love to know more. I actually I'm planning to compare some of the results to the passive technique and see if we can see some differences. And I'm excited to do that. I'm excited to learn more about that.
Yeah. And you have a very unique experience that working on the maxillary-alveolar molding in really delicate way, but also you have experience with Dr. Chate, and right now he just used the special device for nasal molding, and he didn't really do the alveolar molding anymore. I think he just abandoned that. And I think this is a really two extreme trends because people like convenience, and the nose part is really difficult to manage. So the trend seems to focus on that we just take care of the nose part, but for the alveolar, we just reduce that and let the surgeon can easily close the gap. And what's your opinion about that? Do we still need so much efforts to do the alveolar molding, or we just focus on our strengths to do the nasal molding? What do you comments about that?
Yeah, that's a very important question and very interesting question. Thank you for asking that, because like you said, it's the trend, right? I think there are still merit of doing alveolar molding. If you have the resources, I think it's our job to deliver what we know best for the babies. If you don't have access to care, like, or if the patients only have cleft nose alveolus, then I think you can use just a nasal molding type. Personally, I would still opt for the plate with the nasal molding part. But again, it really depends on the context of where the patients are, where you are, how your teams like it, the philosophy of the team. So yeah, everything comes into play.
Okay, thank you. Thank you. Very nice. Well done.
Thank you. Thank you so much.
Dr. Ko. Next, I'd like to invite Dr. Navdeep Bhuthri.
Hi, Dr. Khartoon. It was really nice. Congratulations on the work that you're doing, and it really touches my heart because, all of us who are in cleft field, we know how much we sacrifice to, actually reach the place where we can make the lives of these cleft babies better. And thank you, Dr. Ellen and Dr. Janet. I feel honored to share this ties with both of you. You have both been my very good teachers and mentors. I've learned a lot from both of you. And yeah, so my primary question to you, Dr. Khartoon, was how do you actually predict the movement of the alveolar segments, before you can go ahead and, prepare the second plate? Like, I do understand that until you reach the stage where the, labial frenum is in the mid-sagittal plane, and then you design the second one. But how do you actually predict those movements so that you can actually block out, those areas beforehand to produce subsequent, digital moldings?
Yeah, that's a very great question. So what we did is we tried to align the top of the ridge together, the greater and lesser segment. What we started, because we expect the symmetry for the segment. So what we did is we actually used the mirror image of the greater segment and filled it on the lesser segment. And then we create the plate that way. But you can actually, what we try, you can also do like just a simple blocked out as well. But when we do it, we try to rotate the lesser and greater segment to see the trajectory of the segments that we're making sure we're aligning the top of the ridges.
Right. So because since my training was in Chang with Dr. Ellen and Dr. Eric, so we trained with a single plate where we would just block out this passive plate, and a lot of cases would end up with lesser and greater segments aligning very well on the buccal side, but a lot of cases end up with a like 90-degree or 70-degree alignment. So that's why I wanted to ask, like, how do you actually predict? Because the center of rotation of the lesser segment coming closer to the greater segment coming closer to the lesser segment is not always following that arc that we would predict. So that was one thing that I wanted to ask. And the second thing I would also want to stress on what you discussed with Dr. Ellen, that there are two schools of thoughts when it comes to cleft pre-surgical orthodontics or orthopedics. There's a burden of care. The Eurocleft study was done a long time ago, and a lot of centers do follow that. And just like Dr. Ellen said recently, maybe Dr. Shere, Dr. Pradeep already abandoned the alveolar alignment of the cleft segments. So for me, my take on this would be, I recently presented my research on this in IADR in March. I did this study partially with Dr. Janet when I was there in the Philippines in my MS program. So I had used what we call infrared thermography, in which we converted the thermographic data to objective stress analysis data, in which we found out in different groups which underwent NAM or non-NAM that post-surgery tension in the lip was pretty much zero in the patients who underwent NAM compared to the ones who did not. So this is very difficult to do with, we cannot place electrodes in the patients, in the baby's muscles to know that force. But we still pending the long-term data, which is very difficult for us to, observe. So what is your take on this? I mean, what do you feel? Do you have, is there a study undergoing on the way which, compares patients who underwent digital NAM or the ones who actually did not have a chance to get it?
Well, that's actually a very interesting result. Thank you for sharing that. So I think it's probably have something to do with the, I don't know, the tissue tension because you stretch the soft tissue or not, but that's probably part of it, right? Well, so my answer to your question, we don't have anything under the way, but we have a study underway where we're comparing the result between the conventional way that we're doing and the digital version. What I like to do, if we have an opportunity to, is to compare the results for the incomplete clefts and in the complete clefts. But yeah, we don't have something similar down the road.
Are you doing something similar with bilateral too for the premaxillary retraction?
Oh, so for premaxilla, also that really depends on your philosophy, right? So I don't particularly like to retract the premaxilla. If anything, I'd like to stretch a columella and mold the nose for the baby, center the premaxilla, and stretch the lip. But I don't really want to bring the premaxilla back. So if I can avoid it, and also if you read Dr. Miasini, Maria Costanza Miasini, she talks about ultimately you can bring the lateral segment with headgear when the kids are older, to bring the segment that are actually undergrowth to the premaxilla that is in the right location. So yeah, that's my take on bilateral.
More suggestion. I think it'd be great for you because you're doing a great work on digitizing, NAM. I think it'll be great for you to have a library of different sizes of, NAM plates, which you can actually sort. And then maybe in other centers where we do not have such a, digital you know, set up yet. We could actually get those files in 3D print from you. You could make it, freeware all over the world, for it to reach in places where we cannot have this digital platform.
I like that idea. I never thought of making it, standardized, because everything is very individualized. But like you said, the dimension is actually very, I think, similar in terms of, the cleft gap, the size of the greater segment, the lesser segment. Especially for the digital nasal stent, we have like a standardized size that we can use for all the babies, and it works wonders. So that's something that we'd like to look into more. And yeah, I'd love to contribute. I love when we can share stuff and, advancing the profession.
All right, great. So that'll be all from my side.
Thank you so much.
Thank you. And now I'd like to invite Dr. Janet Pandan.
Hi, Cartoon.
Hi, Janet.
Good to see you.
Good to see
Thank you so much for sharing your amazing work in KKU. In the Philippines, at the North Craniofacial Foundation Philippines, we have just started our journey in digital workflow. So thanks to Smile Train and Dentsply Sirona, so we already have just this year, we already have our intraoral scanners, our printer, and CBCT machine. So my question is, since KKU has adopted the digital NAM protocol ahead of the other centers in the region, so what were your obstacles when you started this protocol? What were your obstacles, greatest challenges, and how did you overcome them? I would be very interested, because we're just starting our journey using adapting the digital workflow in our center.
Well, I can say that it's every steps of the way. Everywhere, starting from finding the intraoral scanner that works, how you can make it work, how you can stitch the file, if you can't get the outside and the inside structures together, the designing, the software. Once you start to learn more, like my advice would be, just do it. When you start doing it, then you'll learn and you will overcome all the challenges that you have. And I think everybody have different experience and different challenges, but it'll be similar, right? To overcome the digital, paradigm. And also for the printing, it depends on what printer you have, what type of appliance. You have to make sure they are cured, there are no residual material that can be harm for the babies.
Biocompatible.
And they're also, they're biocompatible. Also, all these technology, they breaks all the time. They malfunction, they act up all the time. So and then the learning curve, and when you wanted to implement in especially a school setting, it's really hard to teach everybody that have different backgrounds. But we are lucky that our patients are very receptive, and they're just nice people, and I'm just happy to see them.
Yes.
Yeah.
Actually, it's a great learning curve on how to scan. It's the same anxiety that we felt when we first took the rubber impression on babies many years ago. So it's the same anxiety that we feel. I didn't expect it to be difficult at first, but hopefully we'll get there.
Yeah, I think that because I started intraoral scan for many years now, and I think over the years, the software, the scanner, they just improve drastically. And so the ability to scan the soft tissue, it becomes very easy right now. It's way harder 3 years ago. So yeah, I think everybody who wants to start right now, I'm telling you, just do it. Make sure you get the right scanner that can scan soft tissue, and it will work wonders.
Actually, the Prime Scan from Dentsply Sirona is, although the tip is big, but it acquires the data quite fast and really high resolution. Okay, my other question is, do you incorporate growth when you design your aligners?
Yeah, so not right now, but what we did is, because we have the intermediate scan, that's when we capture the growth. And actually, when we design the plate, we actually have like the offset so that it can accommodate some growth for the baby. It would be like the future projects that we wanted to do. to incorporate growth. And I think a lot of groups wanted to do the same thing, to incorporate growth in their design.
How do you determine if you're going to make the adjustment like 1 millimeter per week, or is it 0.5 millimeter? How do you determine like a set protocol, like it should be 1 millimeter per week?
No, not really. So we know that the conventional Grayson used 1 millimeter of adjustment, but when I was at NYU, they already start doing 2 or 3 millimeter per plate. They're not doing 1 millimeter anymore. So it's not efficient when you do 1 millimeter. You let the nature take its course, and the force is to kind of do more work if you allows more, more movement. And because my plate is it's actually have the housing for the alveolar to grow. So there is no limitations. I think that's why we see a faster closure or rotation of the greater segment. And that's when we were able to take intermediate records around 1 month or 1.5 months for the second plate.
So the duration of when you use the IDNAM in KKU, the duration is also the same, like 3 months of PSIO management before you.
Yeah, so yeah, it's a standard practice here that we do. We send the patient for pre-surgery around 3 to 5 months for unilateral. You don't see much changes after 3 months. The alveolar segment won't go, or it won't follow the force anymore. The nose won't be able to, you won't be able to mold the nose anymore. So we try to send the baby. Sometimes in the OR, if they're booked up, then the patients have to wait. But if we can choose, then yeah, around 3 months is perfect timing.
Thank you so much, Dr. Cartoon, for sharing your experience with us. Thank you so much.
Yeah.
Thank you, Dr. Padan. And now I'd like to invite Professor Low for some comments.
Hi, Dr. Kato. It's very nice to listen to your talk. It is quite impressive, and I really enjoy your using the digital technique to do this kind of pre-surgical preparation, and also to prepare the molding device. Yeah, really impressive, and I would really like you to maybe the comment is also question that, have you compared the so-called the impression taking using the conventional way and your so-called intraoral scanning? And so this is the first question for you. And then the second question is that I believe that most of the so-called the clinical management compare from the conventional physical technique to the digital technique actually is the trend to go, because of the current technology of the software and hardware. So I would also like you to comment on the facility, how much to cost in your practice. For example, the software, the scanner, the 3D printer in your department, because for the audience, perhaps not everyone could have this, fortune to own this facility to do the practice. But I believe that in the future, it is the way to go, and I like to congratulate that you have take the advantage of doing this practice. So please answer this question.
Thank you so much. So for your first question about comparing the conventional and the digital, we actually don't have something but related to that. But we review the literature. We know that intraoral scan is accurate enough for us to design the plans for the babies, and also because we already make a lot of kind of like predicted growth is, so to speak, for the plant. So it fits the babies well. But I think that's a great area. If you wanted to do more specifically for NAM babies, you could definitely do so. We actually have all the information, the necessary information to do that study as well. So yeah, thank you for your suggestion. And for your second answer, I think it's actually hard to answer that because different countries, all these resources are at different cost. In Thailand, like our machines are twice more expensive than you can find in the US. So for example, our 3Shape scanner is twice the price in the US. Our 3D printer is also twice the price in the US. I think what's important for the 3D scanner, I think you just have so many options these days and you can find it easily for 400K Thai baht or Taiwan dollar actually. Very similar, right? For our currency. I mean, I'd say total for our department, we probably touching 2 million baht or around 60K USD, 70K USD. But that's also, again, like I said, everything was expensive back then. The printer, I think you still need something that can print the biocompatible resin. But if you're doing the zero plates, you can use very cheap printer. These days they are available everywhere. Any cubic, for example, you can print the model and then you can do zero aligners on it, and that will offset the cost that you're doing. Especially if you're doing like a passive plate, like single plate, like Chang, then you can you reduce the cost like significantly. For the software, again, when I show in my presentation, this is the reason I wanted to do like free software. I want everybody to be able to do it and to really play with it. So you have the recordings. Anyone who would like to start doing digital NAM, please revisit my video. I have the summary of each program's pros and cons, and you can play with it, play around with it, find what works best for you in your setting.
Yeah, thank you very much. Do you have a image lab in your hospital?
Say that
In
again.
your
Sorry.
image lab,
Image lab.
image laboratory.
We have like laboratory, like regular laboratory where you pour models, and then we have 3D printer in our lab as well.
Very nice. Thank you for your presentation.
Thank you, Professor Lo. And now at this time, I think we'll head on to our Q&A session. So the first question is actually from Dr. Dizon, and then the question is, what specific liquid resin do you use for your 3D printing? And have you tried ExoCAD software for the fabrication?
So I use the Dental LT Clear V2 resin from Formlabs. I have not tried the ExoCAD software. I think you have to pay for it, and we just opt for the Blender software, which is free, but we use the dental modules that you have to pay for $300, $300, so to speak, which is not a lot. So yeah, we don't use ExoCAD.
And our next question is from Dr. Cole, and the question is, do you foresee the use of digital NAM to not only alter position of the segments, but also to change the shape or the volume?
I think we already do that with predetermined housing. It kind of like what Dr. Grayson liked to say, like bonsai. So like the bonsai tree, when you mold what is flexible into the shape that you're predetermined. And it goes back to the first question where how I predetermined approximate the cleft segment, because we used the mirror image of the greater segment, and it predetermined the symmetry of the segment, both segments. So I think we already do that in terms of that. For the volume, it really depends on how the baby grows and what comes into play in that.
And our next question is from Dr. Hussein, and the question is, since the objective of the NAM is so multidimensional, do you use it for after lip repair surgery as a feeding pellet or for any other objective?
No, I do not use NAM plate after the surgery. There are studies that show that the baby can feed well even without NAM plate and at pre-surgery. So post-surgery, we don't use anything for that, and we continue to see that the gaps get smaller because there are pressure from the lip, and that's when the greater segment comes closer, become closer to the lesser segment.
And our next question is from Dr. Tansipek, and the question is, what is the blender extension that you are using?
It's on top of my head right now, but I can probably send it to I have to pull up. I can't remember. I think there are three add-ons that we have to use to design this. Yeah, I'm
Okay.
sorry. I can't remember.
And just the last question for you. A lot of people are asking, is there any courses offered at KKU for international students, or do you have any probably internships, fellowships, or observerships that they can apply to?
Thank you for that question. So we actually have trainings for international dentists but we partner with Small Train, and that we had that training 2 years ago. We don't have something out just yet, but we're looking forward to some of it. If we have something, I'll definitely share it with you, and so at least you can promote it for us. I'm more than happy to share. We don't have something planning right now.
Okay, thank you so much. And thank you once again for your great presentation, and thank you for so much for all the things that you taught us today.
Thank
And
you.
before we end this today's webinar, I'd like to invite Dr. Navdeep again, because Dr. Navdeep has something that he would like to share with us. A meeting in Cambodia, right, Dr. Navdeep?
Hi, so yeah, I would like to share my screen for inviting everybody to the upcoming conference in Cambodia.
Yes, please.
Are you able to see my screen?
Yes.
All right, 1 second.
But we don't see it anymore now, though.
Yeah, you'll see in a minute.
Okay.
All right. All right.
Perfect. Working now. Yes.
As you all know, Cambodia Association of Orthodontists is a very young association. It was incorporated just a few years ago, 2016-17, and they attained the World Federation permanent membership, and they are still affiliate member of APOS, and we will soon be permanent member of the Asia Pacific Orthodontic Society this year, full members. So to uplift the standards of orthodontic professions in our wonderful nation here and establish its presence in worldwide scene of orthodontics, we are hosting the first International Congress and Annual Orthodontic Conference, CAO 2024, which is being organized by Cambodia Association of Orthodontists on 19 to 21st October 2024 in the historic city of Siem Reap. So the conference will be in a 5-star venue, and that's Angkor Paradise Hotel in the city of Siem Reap. And the theme of this first Congress, International Congress, will be moving forward to excellence in orthodontics, which incorporates very wide theme of what is going on in nowadays, airway orthodontics, cleft, etc. And for the program, we will have a pre-conference on the 19th by Dr. Himun Kyung. He'll be doing a pre-conference on TADS mini screws, especially in infrazygomatic and buccal shelf screws. On the 2nd and the 21st, we'll have the first and second day of conferences. And we'll have a concurrent expo, dental booth, orthodontic expo going on at that time. And 22nd October will be post-conference leisurely activities. which all of you can join if anybody wants to. So this is our list of international speakers. We have Dr. Eric Liu coming as our keynote speaker. I think everybody of us know him. Other international eminent speakers coming from India, Dr. O.P. Kharbanda, he's a known name in cleft surgery, in cleft orthodontics. Dr. Somchai Satrawaha, past president of Thai Association, everybody here probably knows her. She's done a lot for cleft in Thailand and interceptive orthodontics. Dr. Dennis E. Lim, current president of the Philippine boards, my own mentor in my master's postgraduate program, Dr. Jae-Hoon Park from Kyungpook, Dr. Anmol Kala from India, Dr. William Choi, who is the force behind all the hard work in TAO, Taiwan Association, Dr. Johnson Chang, the head of the orthodontic program in TMU and also a force behind TAO, Dr. Narayan Gandedkar, who himself is a previous fellow of Chang and student of Dr. Eric. He was in Singapore before, now he's in Australia. He'll be flying in. Dr. Him Moon Kyung, I think everybody knows Dr. Him Moon Kyung. He's one of the pioneers of mini screws. And Dr. Muhammad Zainuddin, who's one of my recent colleagues, he also did his cleft fellowship in Chang'an. So all these people will be joining us and sharing their expertise during 3 days of our meeting in October. And we have our 5 national speakers from Cambodia, Dr. Ling Chen Chen, who is actually one of our first founding members of CAO, and she's a Malaysian orthodontist. She's still practicing in Cambodia, and she's a pioneer in orthodontics and pre-interceptive orthodontics here in Cambodia and also cleft. Dr. Mom Savanati, who was the first president of CAO, he's going to be one of our speakers. Myself, I'll be sharing some of my topics. Dr. Sok Cheng Chen and Dr. Chum Mani, who are also one of the few very excellent Cambodian orthodontics. So you will see a lot of diaspora coming from all over the world and also local Cambodian orthodontic scene what's going on. So we'll have CDE points supported by the Dental Council of Cambodia, and those who want to earn more CDE points can join the pre-conference workshop by Dr. Him Moon Kyung, of course, but there will be a separate registration required for that. And this is the list of charges for the actual registration for the conference, which you can also find out on our Facebook post. So City of Siem Reap, as I'm not sure if many of us have visited or not, it has stood the test of time and civilization. As we all know, it houses the oldest Hindu temple in the world, and preserving its beautiful architecture, ornate architecture, with Angkor Wat being one of the biggest, Hindu Buddhist temple complex in the world, which is also a UNESCO World Heritage Site. It is a peaceful, walkable city with loads of adventure activities, relaxing waterfalls, just at a stone's throw. With Siem Reap's heritage, Sihanouk Whales, white sand beaches, Mandol Keris, serene mountains, and Phnom Penh's bustling nightlife, Cambodia has much to offer than what meets the eye. I would highly recommend you considering extending your stay if you are planning to visit to experience the rich cultural heritage and first-class Cambodian hospitality. We eagerly look forward to welcoming you all to the Kingdom of Wonder. On behalf of CEO Board, its members, and people of Cambodia, we extend our humble invitation for you to attend our first International Congress and grace the occasion. Your auspicious presence and support will be paramount and will give an impetus to our endeavors in uplifting the profession of orthodontics in Cambodia and holistically in Southeast Asia. Thank you so much for listening to me.
Thank you so much, Dr. Boothry, for this very rich program that you shared with us. And you're always welcome to post this on our Facebook page for people to further read into it.
Right.
Okay, and also just a reminder to everyone that we also have our Chang'an Forum coming up this October, which will take place in Chang'an Memorial Hospital, and it will take place on October 28th to 30th. So if you haven't registered yet, please do so. And before we take our group photo, I'd like to thank Dr. Cartoon again, and also Dr. Boothry, Dr. Pandan, and Dr. Ko for taking your time here to share your knowledge with us today. And our next ICC webinar will be held on September 22nd, and the speaker will be Dr. Jess Taylor from CHOPS, which is Children's Hospital of Philadelphia, and he will share with us contemporary treatment of the syndromic midface. So please, everyone, at this time, please turn on your cameras and we'll take a group photo.
Thank you again for having me. Can I answer the question about the Blender software?
Oh,
real
yes, please, please.
Yeah, so I just looked up. What we have is the model designer. One is a model designer. The second one is ICP alignment tool. The third one is B4D blocked out. And the fourth one is splint design and layers. And that's all that we had.
Thank you so much for sharing that with us.
My pleasure.
Okay. So I'll count to 3 and let's take a photo. 1, 2, 3, smile, everyone. Okay, let's go on to our next page. 1, 2, 3, smile. All right. Thank you everyone for joining us today. Have a good day, everyone. Bye-bye.
Good night.
Yeah, thank you so much, Dr.
Good
Carton.
night. Good
Thank
night.
you, Professor Ellen Cole, Padan, and Nadeep. Thank you very much. Thank you, Professor Low. Thank you, Prior.
Bye-bye.
Thank you.
Bye-bye.
Thank you.
Okay, Junior, thank you. Yeah,
Okay.
I
See you
have
tomorrow.
to vote. I have to vomit again. Bye-bye.
Bye bye.
Thank you, Iki. Thank you, Iki.
Good to
Nice
see
to
you.
see you.